Hello, welcome back once again to my presentation. I'm Dr. Santosh Abraham. I work as a specialist registrar in Scarborough General Hospital in the Department of Endocrinology and Diabetes. Today I would like to discuss about adrenal incidentaloma, mainly the European Society of Endocrinology guidelines. So, according to the ESI guidelines, if you suspect in a patient an adrenal incidentaloma, or if you suspect that radiologically the patient is having an incidentaloma, or if you find a lesion that's suspicious of incidentaloma, and then you later confirm it with the radiologist, all those patients should have a multidisciplinary team meeting. That's very important. So they recommend that patients with adrenal incidentaloma should be discussed in an MDT if at least one of the following criteria is met. Imaging suggests that it is not a benign lesion. There is hormone production, excess hormone production, including the autonomous cortisol secretion, and there is significant tumor growth, and if surgery is being considered. So it will be referred to the MDT if the imaging shows that it's a malignant lesion, or if it is suggestive malignant lesion, there is excess hormone, or there is significant tumor growth with the follow-up imaging, or if you are considering surgery for this patient. So, assessment of the risk of malignancy. Why do you want to assess this? To establish if the mass is benign or malignant at the time of initial detection. So, all adrenal incidentaloma undergo an imaging procedure, which is basically a non-contrast CT. So, if the ultrasound is suggestive of any adrenal mass, or if you are doing a CT scan for any other issues and then you find an incidentaloma, basically you begin with the non-contrast CT. So in the non-contrast CT, if the mass is homogeneous, lipid rich, it's considered to be benign. But if it is considered, if the non-contrast CT is consistent with the benign lesion, there is no further imaging required. So radiologically, it means that the adrenal mass will have an HU less than or equal to 10. It will be homogeneous, and its size will be smaller than 4 centimeters. So these are the three criteria: HU less than 10, homogeneous, and smaller than 4 centimeter. So if radiologically you find a benign lesion, no further imaging is required. So imaging criteria: non-contrast CT is really good. So it's superior over the MRI. In the MRI, you basically use the loss of signal intensity on outface imaging, so which correlates with the lipid-rich adenoma. But in the non-contrast CT, you are basically relying on the density. So you're relying on the Hounsfield units, and also you could use, with the contrast CT, you could use the washout method. So the absolute washout more than 60% and the relative washout more than 40% will show that the mass is benign, even though the superiority of the washout is not much significant. So basically, if you have the non-contrast CT of less than 10, it's more than enough. In another modality for imaging used is the 18 FDG PET scan. So the absence of FDG uptake or uptake less than liver will show, which is usually done in case of mets, will show metastatic carcinoma. So that's the single reason why the FDG PET is used in an adrenal mass. So basically you have 4 modalities: a non-contrast CT, a CT with contrast, and using the washout technique, the MRI and the FDG PET. The MRI is not superior over CT. The contrast media washout is also not superior, and the FDG PET you use in metastatic cancers or advanced cancers. Will you do a biopsy? No. You will not do the biopsy unless there's a history of extra adrenal malignancy. So they do basically recommend against the use of an adrenal biopsy. Why? Because if you do a biopsy, it runs the risk of tumor dissemination. And assessment for hormone excess. So in every patient with an adrenal incidentaloma, he or she should undergo careful clinical assessment for signs and symptoms of hormonal excess. So the basic test is to do a 1 mg ODT or the overnight dexamethasone suppression test to exclude cortisol excess. So the interpretation of the results of the ODST should be continuous rather than categorical. The categorical here means it has no absolute answers like yes or no, but it is interpreted on the background of the clinical signs which the patient is having. So if you have a serum cortisol post dexamethasone less than 50 nanomole per liter or less than 1.8 microgram per deciliter, it excludes autonomous cortisol secretion. If the cortisol exceeds more than 138 nanomole per liter or 5 microgram per deciliter, it is an evidence for autonomous cortisol secretion. So anything less than 50 nanomoles, you exclude the autonomous cortisol secretion, and anything more than 138 nanomoles per liter, you can be definite that there is autonomous cortisol secretion. But a value in between the 50 nanomoles per liter and 138 nanomole per liter should be considered as possible autonomous cortisol secretion. So additional biochemical tests may be needed to confirm cortisol secretory autonomy and assess the degree of cortisol secretion. But for clinical management, the presence of potentially cortisol related comorbidities and the age of the patient are of major importance, which means that it's not mere the values, but the clinical signs, the comorbidities, the age of the patient are also taken into account when you want to manage these patients. So the risk of autonomous cortisol secretion into developing overt Cushing syndrome is very less. So they do not recommend screening, surveillance screening, considering autosomal cortisol secretion. So they don't consider autonomous cortisol secretion. I'm sorry, they don't consider autonomous cortisol secretion as a risk factor for developing Cushing syndrome, but they do recommend screening with possible autonomous cortisol secretion and autonomous cortisol secretion because these patients have got a high risk of developing hypertension and type 2 diabetes mellitus. So they might need the appropriate treatment. So the guidelines definitely tell you that there is a low risk, or the risk is quite less to develop overt Cushing syndrome even with autonomous cortisol secretion. But they do recommend screening in patients because of the side effects of the cortisol. Does the patient need a vertebral fracture screen? So in patients with asymptomatic vertebral fractures, you need to screen for autosomal cortisol secretion. This is because you need to consider appropriate treatment for them. So it could be done by evaluating available images if a CT was done, or by a plain X-ray. The ESE had no consensus for recommending a DEXA scan as a part of the vertebral screen. So this is basically an algorithm which dictates how to proceed with the management. So when you have a normal cortisol secretion, that is when there is no possible autonomous secretion or autonomous secretion, even if you have comorbidities, there is no need for surgery here, so no surgical removal needed, and there is no need for reassessing cortisol excess. But if you have a possible autonomous cortisol secretion, if there are comorbidities, rarely you might need a surgical removal, and definitely you need to reassess the cortisol excess and comorbidities during follow-up if there is no surgery is being done. So in patients with possible autonomous cortisol secretion, if there are no comorbidities, you don't need to follow up, you don't need to think about surgery. But if there is a comorbidity, yes, you should reassess the cortisol excess and comorbidity during the follow-up, and may rarely require surgery. What about autonomous cortisol secretion? Well, if you have comorbidities, mostly surgery has to be considered, and cortisol excess reassessment should be done if the patient is not for any surgery. Rarely do these patients with autosomal cortisol secretion do need surgery if there are no comorbidities, and but they need to be reassessed for the cortisol excess during the follow-up. So the follow-up is required basically in the possible autonomous cortisol secretion if there are comorbidities, and in autonomous cortisol secretion if there are comorbidities and if there are no comorbidities. So in every case of autonomous cortisol secretion, the follow-up for cortisol excess should be done, but in possible autonomous cortisol secretion, the follow-up is done only for patients who have comorbidities. I hope that's clear for you. Regarding surgery, an individualized approach in patients with autonomous cortisol secretion has to be considered if there is a benign adrenal adenoma. The comorbidity is potentially related to the cortisol excess dictates the indication for surgery. So age, degree of cortisol excess, general health, comorbidities, and patient's preference are all taken into account. In all patients, ACTH independency of cortisol excess should be confirmed. That's very important, because if it is ACTH dependent, you're not going to do the surgery. So you can find it out by a suppressed basal morning plasma ACTH or a low basal morning plasma ACTH. So a suppressed ACTH or a low morning ACTH will indicate that should be done, will indicate that will rule out the ACTH independency. Another point is that you need to definitely exclude pheochromocytoma. So they do recommend doing plasma-free metanephrines or urinary fractionated metanephrines. In patients with hypertension or unexplained hypokalemia, they recommend the use of ARR, that is the aldosterone-renin ratio, to exclude primary aldosteronism. So pheo has to be excluded, and primary aldosteronism has to be excluded in patients with hypertension or unexplained hypokalemia. Sex hormones and steroid precursors could be measured if there are features of adrenocortical carcinoma. Because in adrenocortical carcinoma, more than half of the cases, sex hormones and steroid hormones are elevated. So that's why if adrenocortical carcinoma ACC is suspected, you can do sex hormone and steroid precursor assay. So more about the surgical treatment. They do recommend adrenalectomy as a standard of care for unilateral adrenal tumors with clinically significant hormone excess. So for unilateral adrenal tumors which are secreting hormone more than normal, adrenalectomy is the choice. So, but if the patient is asymptomatic, the mass is non-functioning, and there are benign features on imaging studies, they recommend against performing surgery. So in all such patients who don't have symptoms, if the mass is non-functioning and obviously benign radiology, there is no need to proceed with the surgery. So in unilateral adrenal masses, laparoscopic adrenalectomy is the preferred mode. So if the radiological findings is suspicious of malignancy and with a diameter less than 6 cm but without evidence of local invasion. So in adrenal masses which are unilateral with a diameter less than 6 cm without evidence of any local invasion, you go with a laparoscopic adrenalectomy. So once again, I would like to tell you that if the adrenal mass is unilateral, the diameter is less than 6 centimeters and there is no local invasion, you go with the laparoscopic adrenalectomy. But you do an open adrenalectomy if the diameter is more than 6 centimeters, if you are suspicious of malignancy, and if there is signs of local invasion. So if the diameter is more than 6, if the mass is suspicious of a malignancy, and if there are signs of local invasion, you will have to go for the open adrenalectomy. So patients who fall in between these two categories, they suggest an individualized approach, and a customized approach for them. So this is a beautiful algorithm which describes the ESE guidelines regarding the surgical management. So for unilateral adrenal mass, if you have a suspicion of malignancy and if there is local invasion, yes, go for open adrenectomy. If there is no local invasion, if the diameter is less than 6 cm, yes, individual surgical approach. If you have a suspicion of if you have no suspicion of if there is no local invasion and if the diameter is less than 6 cm, you go for the adrenalectomy. But if there is no local invasion and if the diameter is more than 6 cm, you go with the individualized surgical approach. So once again, I'll tell you, if there is radiological suspicion of malignancy, if you suspect malignancy, if there is a local invasion, you go for the open procedure. But if there is no local invasion and if the diameter is more than 6, you go for the individualized surgical approach. But if the diameter is less than 6, you go for the lap. Okay, if you find a unilateral mass with no malignant features, but if they have hormone production excessively, then you go for the lap. But if the lesion is benign and if there is no hormone excess, then no surgery is needed. So I hope it's clear now. So they do recommend perioperative glucocorticoid treatment at major surgical stress doses. So in all patients undergoing surgery for an adrenal tumor, where there's evidence of possible autonomous cortisol secretion or autonomous cortisol secretion. So perioperative, during the surgery, you need to replace the glucocorticoids. How about the follow-up of patients not undergoing adrenal surgery? So they do suggest further imaging during follow-up in patients with adrenal mass. So sorry, they do not suggest any imaging for patients with an adrenal mass less than 4 cm, and imaging suggests that the mass has got benign features, so which I've already told you. So there is no follow-up needed for those patients if the size is less than 4 cm and the radiological features suggest that it's benign. So benign imaging and mass less than 4 cm, no follow-up needed. But if you have an indeterminate mass and you have no idea on imaging, if the patient or if you decide not to undergo any adrenalectomy, a repeat non-contrast CT after 6 to 12 months is needed. This is because most of the adrenocortical carcinomas grow rapidly within 3 to 6 months. So you are always worried about whether this mass will turn out into an ACC, which will then need an open procedure. So to rule out that, they always recommend a follow-up in 6 to 12 months. And beyond 12 months, there's a rare possibility of the mass turning out into ACC. So in short, if the mass is going to be an it's going to be an adrenocortical carcinoma, it will grow rapidly within 6 to 12 months, so mostly within 6 months. So that's why you need a follow-up if you're not performing a surgery for all those masses, if the radiological features cannot be determined during the CT scan. So what if you have not done the surgery, but if the lesion enlarges by more than 20%, that's a 5 mm increase in the maximum diameter in this period, in the 6 to 12 months period, you go for the surgical resection. So if the lesion enlarges by more than 20% in 6 to 12 months, surgical resection. If there is a growth of the lesion below this threshold, that is below 20%, again additional imaging after 6 to 12 months might be performed. So when you're not very sure whether the mass is going to be an adrenocortical carcinoma, you need to follow up again with imaging. I hope the follow-up is clear for you. So what about the hormonal workup? If the patient had a normal hormonal workup at initial evaluation, there is no need for a repeated hormonal workup if there is no clinical signs of endocrine activity, or if there is no worsening of comorbidities, like if the patient is not having any hypertension or type 2 diabetes, or if the patient is not developing any hypertension or type 2 diabetes, or if there are no other features of endocrine activity appearing as new, no need for repeated workup. But if you have an autonomous cortisol secretion but without any signs of Cushing's, you need to evaluate them for cortisol excess every year. So annual clinical reassessment for cortisol excess, and also for the comorbidities potentially related to cortisol excess, which will include screening for hypertension, type 2 diabetes, etc. So based on the outcome of this evaluation, potential benefits of surgery should be considered if the effects of the hormone excess is going to decrease the lifespan, or if it is going to increase the morbidity of the patient. So for autonomous cortisol secretion, even if they don't have any signs of Cushing's, you need to annually assess them for cortisol excess and also for any new comorbidities developing because of the cortisol excess. Okay, in special circumstances, so in patients with bilateral adrenal masses, each lesion is assessed at the time of detection according to the same imaging protocol as for unilateral masses to establish if either or both lesions are benign or malignant. So each lesion should be individually and separately assessed radiologically whether it's benign or malignant at the time of detection. So if you have bilateral incidentallomas, they should undergo the same workup, they should undergo the same clinical screening, they should have the same hormonal assessment as in with unilateral incidentaloma. So the same applies for the assessments of comorbidities that might be related to autosomal cortisol secretion as well. In addition, this is very important, the serum 17-hydroxyprogesterone should be measured. Why? You need to exclude congenital adrenal hyperplasia. So the 17-hydroxyprogesterone should be definitely assessed. And then testing for adrenal insufficiency should be considered, because if you have imaging suggestive of bilateral infiltrative disease, or if there are hemorrhages, or if there are clinical grounds to suspect adrenal insufficiency, the test for adrenal insufficiency should be done. So if there are clinical signs, if there are bilateral infiltrative signs on radiology or hemorrhages on radiology. So the recommendations regarding the indications of surgery, the follow-up are the same for bilateral incidentaloma. So in bilateral adrenal masses, bilateral adrenalectomy is not usually performed for autosomal cortisol secretion if there are no clinical signs of overt Cushing syndrome. This is very important because this is frequently tested in the SE exam, and you might be having questions based on this. And if you see bilateral adrenal hyperplasia without any features or without any comorbidities, don't think about surgery, because you don't want to have the patient lose their adrenals and leave with glucocorticoid supplementation. So leave the hyperplasia or leave the bilateral adrenal masses alone. even if they have elevated cortisol, if there's no sign of Abbott-Cushing syndrome. But in selected patients, a unilateral adrenalectomy of the dominant lesion might be considered, considering age, degree of cortisol excess, general condition, comorbidities, and patient preference. This is according to the ESE, but I think this Endocrine Society has got a different approach, because they might tell that if a dominant lesion is removed, the remaining lesions which lie dormant could become hyperactive, and they could they could again produce excess hormone. So I think they don't agree with that, so possibly they don't agree with partial adrenalectomy as well. What about in young or elderly patients? So you need urgent assessment in children, because it's not very common, in adolescents, and in pregnant women, and even in adults less than 40 years, because there is a higher risk of malignancy. So the risk of malignancy increases in children, adolescents, pregnancy, and adults less than 40 years. So they need an urgent assessment. Now in children, adolescents, and pregnant women, because of the risk of radiation, we prefer MRI. And if dedicated adrenal imaging is required, even adults below 40, the ESE recommends an MRI. So if you're trying to treat, you should always consider its general health and the degree of frailty, because you're not going to treat actively if the patient is quite frail and if they have a lot of comorbidities. And that the decision to treat has to be reviewed. Especially in the MDT, you will have that decision reviewed, and you will have a plan in place. So, okay, now challenges. Newly diagnosed adrenal mass with a history of extraadrenal malignancy, even though rare. So recommend the measurement of plasma or urinary metanephrines to exclude pheochromocytoma with an extra-adrenal malignancy, because you know that pheochromocytomas can be extra-adrenal. In an indeterminate mass, so you need to exclude pheochromocytoma, even if the mass is likely to be metastasis. Why? Because if you don't rule out, the consequences will be deleterious. So in patients with history of extraadrenal malignancy, FDG PET scan is performed as part of the investigations for the underlying malignancy. So you basically do the adrenal to the liver ratio, and then a ratio in the range of 1.5 to 1.8 suggests, it has got a higher sensitivity, so it could suggest malignancy. So that's done here. So decreased uptake in the adrenals, basically. So in patients with history of extraadrenal malignancy, adrenal lesions which are benign require no further specific imaging follow-up. So if the lesions are benign, even in extraadrenal malignancy, they don't need a follow-up. For indeterminate lesions in extraadrenal malignancy, you need to follow up. Why? Because they can grow. So for the potential growth of the lesion, you need to follow up. As you do the imaging for the primary malignancy, you need to do the follow-up for this. So it is recommended to do imaging follow-up to assess the potential growth of the lesion at the same interval as imaging for the primary malignancy. Alternatively, surgical resection or FDG PET CTs or a biopsy can be considered. Now this is one of the very rare moments or very rare occasions where you do a biopsy. So when do you perform a biopsy? Usually it's not done, but it's done in these criteria. If the lesion is inactive, and if you have excluded pheochromocytoma, definite. And it is not characterized as benign by imaging. That is, it's indeterminate, it's inactive, and if you are sure that you can manage, if you get to know the histology. So in short, if the lesion is inactive, if the lesion could not be characterized as benign by radiology, and if you believe that management would be altered by the knowledge of the histology, definitely, or you could even consider biopsy, but it's not usually recommended. So in patients with large bilateral mets, you need to assess residual adrenal function, because if you are considering for surgery. So okay, so I'll just show in short how the ESE guidelines are for the adrenal incidentaloma. So if you find an adrenal incidentaloma, first the MDT, and if it shows features of malignancy, or if it is uncertain, so so you are doing whether it's malignant by non-contrast CT. If you're not very sure, you could do all others like the PET, MRI, washout CT, whatever. And if it's functionally active, is it functionally active by clinical assessment, but by 1 mg ODST, by metanephrine, and by ARR, and all. And then you come to a definitive diagnosis. So if it is having autonomous cortisol secretion, if it is malignant, or there is hormonal excess, or if it is indeterminate, you have to discuss in the multidisciplinary team, and then you do the appropriate management. So if it's indeterminate mass, you have to do the follow-up, and the follow-up later on could turn out into surgery. But if it is non-functioning, it's a benign lesion like an abnormal lipoma. There are no further investigations are needed. But if it is an adenoma, then if there is hormonal excess, you go for the laparoscopic adrenalectomy. But if it is if there is suspicion of malignancy and if there is local inflammation, you go for the open adrenalectomy. But something in between, like if there is no local invasion but it is suspicious of malignancy, but if the diameter is less than 6, you have an individualized surgical approach. If it is less than 6, if there is no local invasion but you still suspect malignancy, you go for the laparoscopic adrenalectomy. But if it is more than 6 and it's malignant, possibly open adrenalectomy. So again, coming back to the management based on the cortisol secretion. So if it is possible autonomous cortisol secretion, if there are comorbidities, then follow up. If there are no comorbidities, there is no follow up. If there is no hormone secretion, even if there are comorbidities, no follow up. And if it's all normal, no follow up. And if you are sure that it's autonomous secretion, then if there are comorbidities, you could consider for surgical removal and follow up definitely. But even if you don't have any comorbidities, you do follow up. So follow up in cases of autosomal cortisol secretion, even if you have comorbidities or not, and possible autonomous cortisol secretion when you have comorbidities. So in these 3 cases, you need to follow up. That is with possible autonomous cortisol secretion, with comorbidities, yeah, you need to follow up. With autonomous cortisol secretion, whether you have comorbidities or not, you need to follow up. So in these 3 cases, you need to follow up. Thank you. Thanks for being with me. We'll catch you up with the next presentation. Bye.